All right, good morning or good afternoon, everyone. Welcome to the EMS Interoperability Task Force call for October 2023. I'm Josh Legler, leading the interop efforts on behalf of the NEMSIS TAC. Amit Trivedi represents HIMSS and IHE. Before we jump into today's call, Amit suggested to me that maybe we do some intros for any new people that have joined us in the last, you know, couple months, or if today's your first time on this call. So I'll kind of open it up right here and see if there's anyone new on the call that would like to just introduce themselves and a little bit of their background and why you're on the call. So any new people?
Hey Josh, it's Lee Prush from ESO. I'll jump in and introduce myself. So I'm the Senior Director of Interoperability here at ESO, relatively new to the organization, part of the product group, and my background is automated patient record matching and clinical data integration, and glad to be here. Thanks.
Great, thanks, Lee. And we're probably going to bring Lee on to share some information in the November call when we talk about patient identification and matching. So yeah, thanks in advance for helping us out with that.
You bet.
All right. Any other new people? Okay. All right. Well, let's get going with today's call. So today we're going to go into the topic of how EMS gets patients' medical history at the front of an EMS call. Before we dive into that topic, just a few upfront things to cover with you. First of all, just give you the 30,000-foot view here of where we are so far. So we've been meeting monthly this year, have hammered through a lot of topics. We will meet again on November 9th. And then in December, we will not have the usual second Thursday task force call. We'll have the ONC annual meeting happening that day and the EMS data summit the next day, which I'll talk about in a minute. But after today's topic, we will have wrapped up looking at the standards and profiles that would be used in the various steps of the EMS interoperability workflow. And so then we will move on to the topic of patient identification and matching. And then we have a few topics to cover next year. One is data elements to be shared and parsed. And I think that's actually going to be one that we're going to dive into and break into multiple calls so that we can look at each step of the workflow and identify, for example, today we're going to talk about the standards and profiles used for EMS to get a patient's medical history. But in a subsequent call next year, we'll dive into the content that the EMT or paramedic needs that can be extracted from those documents. So looking at the specific things that are important to them to pull out of those documents. So we'll take a few calls with that. And then we also want to touch on APIs, make sure everyone knows what APIs need to be used for interoperability. So we're probably going through the first half of next year with task force calls based on the remaining content that we have so far. Okay, I want to mention again the ONC annual meeting and the EMS Data Summit. The ONC annual meeting is being held in Washington, D.C., December 14th and 15th. You can go to oncannualmeeting.com for registration and the agenda. Registration is free of charge. You just got to get yourself to Washington, D.C. On the afternoon of the 15th, we will hold an EMS Data Summit. So it'll be during the final few hours of the ONC annual meeting as one of the breakout options. So that'll go tentatively from noon to 3:30 p.m. We might have to start a little later so you can all get lunch. And that will be available not only for people attending in person in Washington, D.C., but it'll also be available for online participation. So you can register at the link provided there for the EMS Data Summit. So if you are registered for the ONC annual meeting, it's important to make sure that you also register for the EMS Data Summit. so as a separate registration. And when you do that, you can indicate whether you're going to register as in-person or attending online. In terms of what we're going to cover at the Data Summit, we're going to pick up from the 2020 Data Summit that was held. It's hard to believe it was almost 4 years ago. EMS data more integrated with the rest of healthcare. We've identified some challenges that we're going to have presenters on and responses and see if we can figure out paths forward on these things. So these challenges would include getting EMS at the interoperability table, how we get support for operations queries, which is what EMS needs to get outcome data, how to participate in the existing healthcare information networks, and of course, the question of funding. So the Data Summit gives us the opportunity to tackle more of the policy perspective, because on the task force calls, we're really diving into the technical stuff, but we recognize that there are policy needs. So that's what the summit will be about, and we welcome all of you to attend either in person or online. Any questions that any of you have or comments on the upcoming Data Summit? Jonathan?
Hey, morning. Just real quick, just a sort of point of caution since you mentioned there about funding. Careful on that one. You're going to have companies in the room together. There are very important federal limitations on what organizations are allowed to come together and discuss when it comes to financing and money. So lest anyone in the room be accused of antitrust actions, we want to make sure that we are extremely careful on what gets discussed in that regard. It might be helpful to lay out, I would strongly recommend lay out ahead of time what you'd want to talk about so that folks can weigh in on it. If it's public funding, it's a little bit different, but grants are one thing. If it gets down into things like how organizations potentially have a business model around interoperability, that is illegal to discuss in a room together. So I think it would be we just want to make sure we're careful on that one. I know that, yeah. I know that, I mean, obviously it's a big open question. So it just that's something that there are others in the room who are going to be more nervous about that than any of us. Anyone from Commonwealth, for example, they had to have lawyers present at every single meeting that they were at because when you put Epic, Cerner, et cetera, in a room together, they are not allowed to discuss certain things. And we have to make sure that we abide by that as well. I think that could come back to haunt us if we don't.
Okay. Yeah, thanks for that caution. I think we're looking at the public funding opportunities and what ONC might be able to help with in terms of helping people understand where public funding is available. But yeah, thank you. Okay. All right. Let's see. Okay, there's one other thing I want to mention before we dive into today's topic. Way back in April on our task force call, we talked about putting together a letter that would go to ONC about EMS on interoperability and kind of the high level needs to move things forward. It's been a long time kind of working out like where the letter is going to come from and who it's addressed to and all that. And we've finally made progress on that. We have a draft that we're working on. So you'll probably hear from me soon with a draft that all of you can be taking a look at. Eric Cheney at the Office of EMS at NHTSA has determined he would like it to go from someone at NHTSA to someone at ONC. But we want all of the stakeholders throughout the industry to be aware of what's in that letter and to have an opportunity to provide edits or comments on it so that it really represents the collective voice of the EMS industry, even though it'll be written from a federal agency to another federal agency. So more to come on that soon, but we're excited to finally have some movement on that. Okay, let's jump into today's topic. We had a couple people that we had reached out to potentially contribute today who were kind of tentative and I think maybe ended up not being able to make it. But I know that everyone on the call has a wealth of background that you'll be able to contribute today to help us answer these questions on today's topic. So we look forward to the contributions from all of you. We're going to be diving into the standards and profiles to use for EMS to query for a patient's medical records and then to retrieve a medical record on that patient. So I'm hoping we can answer these two main questions here. What standards and profiles are used for the query of patient medical history data and the response to that query? And then when you ask for a document, a medical record, what standards and profiles are used for making that request, and what format is that document expected to be in? So at a high level, we're talking about this step in the summary high-level paramedicine care flow. Notice here that we today are not talking about step number one, the patient lookup. So for today's call, we are assuming that we have figured out the identity of the patient. Next month, we're going to talk about how to do that. But for today, we assume we know their identity, and we query a network for medical summaries. And then we get what might be the best or freshest, most recent medical summary from the network. So that's what we're looking at. We're also not looking at specifically what content the EMT or paramedic might need to be shown from that document. That's going to be a future task force call to parse out the specific data. But just looking at that step of searching for and retrieving the document. Okay, so diving into the detailed flow, and this is where we'll spend our time today. So we're going to, do that patient lookup, like I say, skipping that for today. And then we start up with step 3 there, look for a medical summary. We get a list of medical summaries, pick the best one, and retrieve that document. I want to just stop on each of these links that we have on the slide and explain what's here so far on this diagram. And then as we go through each of these, I would love the input from all of you about, what are you actually seeing out there today in terms of how this stuff is actually working. So the first note here is that it's to query for a LOINC code. And so let's take a look at that LOINC code. That LOINC code is for a summary of episode note, and it indicates that this would typically be a continuity of care document. Let me bump up the size of my screen here. As I scroll down, I can see that it in fact references the CCDA release 2.0 and 2.1, as well as CCDA 1.1 with the various sections that could be contained in those. Okay, so putting in a query to the network for a summary of episode note, which is likely going to give you a CCD. Does that sound good so far? For those of you who have implemented these types of queries, is that how it's happening? I see from Matt at No2, this is what we see nearly always in query-based networks like Care Quality and soon to be TEFCA, eHealth Exchange, in terms of a patient-level document that would be on all patients in addition to encounter documents. Thanks. Okay, so we're probably good on that. I'm going to make a quick note here on the on-demand document entry. So that takes us to an IHE white paper, and it indicates here that an on-demand document is one where the source publishes a promise to produce a document of a specific kind, but it's expected that that content will change over time. So the idea is that once you actually ask for the document, they actually compile the document at the moment that you ask for it, and then return it to you. Okay, and then I want to spend some time. So you'll get a list of medical summaries back. Actually, let's pause there for a second. Uh, any, well, let me catch up on notes here, actually. Um, yes, Steve Rotman got a promotion to CEO of Wishin, so congratulations, Steve. And let's see, Steve said not all hospitals use LOINC, at least in Wisconsin. Many are still using internal codes. Okay. So, Steve, could you talk to us about how that affects the query? So, you put a query in using that LOINC code, but you're saying that there are hospitals that are just using different codes, so they would not return a result?
Yeah, most of our queries aren't for specific codes, but for documents of patients. So we're not seeing query. And I'm sorry, I'm thinking about your question in real time and answering.
Yeah.
We're not seeing queries for specific documents that include codes. Those codes would be included. Now in CCDs, it is true now that I talked through this in the CCDs, that is accurate. It's but it's not 100%. So that's something we are looking at as part of a quality work group here in Wisconsin through the HIE. Like, who's sending what and what standards are they using? If there's a gap in the standard, then how do we work through those vendors? Not all are created equal is just, I guess, what I'd say.
Yeah. So to get around that, would someone submit a query and just not specify that LOINC code and potentially get lots of different documents?
That's generally what we recommend from the no-to side. Sorry to interrupt here, but yes, in terms of what happens, there are 3 steps for that query process. That second step is the document query, where you request what documents are on a patient. We don't recommend in general, and especially for EMS groups, that you filter based on that. So that you receive the full document list. Now, once you have the full document list, what you actually query for to retrieve can be based off of like logic of, we want 34133-9 first, we want the discharge summary next, that sort of thing. But in terms of getting the full list, we generally don't recommend you query for that. Just so what Steve says, in terms of if folks that do it differently, folks that use internal LOINC codes, at least you're understanding the full conglomerate of what they have, and then you can request what documents you actually want from there.
Okay. Yeah, makes sense.
I guess that works if you're willing to understand all possible document types, that infinite set. But if all you're able to process is a CCDA, then why not just ask for the CCDA?
I mean, you could do that if that's all you can process. It's certainly fair. I think understanding if the organizations are using other class codes that you may need to adjust to in the future, or if there's a patient level CDA that's not 31433-9, you can understand that too. But at the end of the day, if you request, even as a middle ground, if you request for all of the documents in the document list and then just only actually retrieve that patient level CDA, that works too.
Yeah, I agree with you. This is John Murky, by the way. The reason why I was recommending the query be specific to CCDA is trying to help the community, the EMS community, crawl before they're expected to understand all possible encodings, including, getting back HL7V2 fragments and DICOM objects and all kinds of other things that they might get if they ask for all possible documents.
Yeah. And so I'm definitely saying don't actually retrieve all those documents, but only retrieve the documents that you can process. But at the same time, any CCD, whether that is, or any document that has a narrative, whether that's an encounter level document, a patient level CDA, or whatever, you can generally use just a standard renderer to at least show the clinician what's in the document if you can't even parse out the discrete data, which is certainly fair to do.
Yeah, I hope we're not still just rendering XML through a style sheet to the EMT who's quite urgently trying to get the right thing.
Right, but I know some are.
I'm trying to be very sensitive to the use cases here. But it's possible that we switch this and say you query for all, and then you locally filter down to the CCDA.
I'd be on board with that as long as we can understand. I would want to add a couple of class codes to that to challenge folks, because especially on the encounter level documents, you're going to get discharge summaries that are going to be really helpful and that are generally under only a couple codes. But yes, understood.
Well, at this point in time, we're looking for medical summary. Later, we look for discharge.
Yes, I agree. And we can dive into that in future calls. I think getting all information that you can on a particular patient, especially that stuff that isn't contained in a patient level document, especially from some of the bigger vendors, we can kind of talk through and see if we want to go there or not. But we've seen value in notes and things like that you can't find within a patient level CDA generally.
Yeah, in general, I agree. Full stop.
I think we're saying the same thing, John. We're just
bound and rather size bound. So, okay. Now, at least we understand that. That's the important point of the hour, right, is to understand.
So, Steve, in your network, when you say there's hospitals that are not using that code, are these hospitals that potentially are they're producing a document that could be a CDA of some kind, or it could be just a totally different document?
Yeah. So I'm starting to encroach on the limits of abilities here. So I'll take some of these comments and questions back to my team. Again, I am nowhere as versed as Matt. So I appreciate him being on the call and being able to help guide us through this conversation. But let me get some feedback from my team, what we're seeing and how this is providing value in the steps we're taking with image trend. Like I've shared with this group, like we're working on that hospital output automated query for documents for patients. How this specific LOINC code, and I don't know enough about this LOINC code that's being mentioned here. So let me take that back. And if there's any other questions that Matt or John or Joshua, you all have that we can take back to what we're providing, happy to do that and report back.
Yeah, great. Okay. Yeah, that sounds good, because I think like we want to make sure that we don't just send in a query and get nothing back, or when a hospital or a healthcare provider actually has something they could have given, but if it's in some format that we can't anticipate, then like Matt was saying, the best we can do is just render it, which could be problematic for an EMT in an emergency situation who needs a little bit of info quickly. But if they are returning documents that essentially are in CDA format, but they've just for whatever reason chosen different LOINC codes, that's a potential area that we could work with, I guess.
And I don't know, Matt, if you have a comment to this, or maybe John, where we're getting to with this discrete data points. Again, I don't know enough about how to pinpoint and query on this. I'll ask the questions, but using FHIR in a US CDI specification, if we're looking at specific data elements, maybe that's where we should direct our vision to. I'm not trying to disrupt this, but maybe CCDAs from all, and not all are ready for fire either. So we'll have to crawl, walk, run through this. But I mean,
Right.
fire resources for specific elements, that might make more sense to those that, as Neil mentioned, like we need treatment information in the moment. Going through, and some of these CCDs are large documents. Let's not forget that. Like if there's high utilizers that EMS are very used to having contact with, these might not be 4-page documents. These might be 120-page documents.
Yeah, understood. And so I think there's 2 points there. Number one, I think I agree with you. I would love a fire ecosystem where fires at scale, we're able to do this across the country just with fire. We're not right now, unfortunately. Hopefully TEFCA will take us there. That's their goal, but we're not there yet. So we have to use CDA at some level to get that national coverage through frameworks like air quality and others. I think the second point there is with CDAs, if you're looking for very specific pieces of information, programmatically, you're able to parse those out without, yes, you would have to consume all of the XML internally. You wouldn't have to display that necessarily. And there are some things you can do in terms of actually parsing through that discrete data and getting to like a medication and allergy list, for example, to just display. And so we could talk through that as well, which I'm sure you know. But at the same time, yes, the CDA is generally kind of big in terms of consumption, in terms of expensiveness, in terms of actually consuming it. But hopefully we can get to a place where that doesn't actually affect the EMS person that's on their run.
Yeah, Steve, I pretty much hit what I wanted to say, but I'll point out that we're focused here on the most success criteria because we have a nationwide network today that has broad agreement of publishing medical summaries, and we don't yet have a nationwide fire system. To Matt's point, and to react to one of the points I made earlier when someone said, oh, just display the CDA using a style sheet. No, we're expecting that there is an EMS value add intermediary that is consuming these documents, deduplicating, finding the freshest of the data that's across the networks and presenting a fire API to the actual EMS. So we sure are not expecting a CDA to go to the ambulance. We're expecting a value add API is going to leverage the fact that we have nationwide network that has medical summaries in it today. And if that turns over to being a nationwide network of fire resources, so be it. But that's not today.
John, I wanted to Steve, on your concern about whether the organizations can actually respond to a request for a CCDA, this is with meaningful use, this was the lowest level. So all certified EHRs can respond to that. And I think probably 95 to 99% of the hospitals in Wisconsin, maybe 100%, are able to do just this. In Texas, there's only one hospital that can't, that's still paper. So I think you're probably good. And I really liked what I think it was Matt who said earlier, trying to make sure that we start with something that we know that everybody can respond to is a good way to start the journey.
Yep. Amen.
Yeah, just to be clear, the issue is not responding to under the meaningful use stage 2 and certified EHRs. It is responding to specific queries for this specific LOINC code.
This LOINC code is the code assigned to CCDA, and it is required. We're
It's
not
already
talking about
there.
the line codes inside the document.
Yes.
We're talking about the document.
Yeah. Okay.
Yeah.
That's what I wanted to be clear. Not codes
Yeah,
within, but the document itself.
Yeah, this is the code for the document. This is a document code.
All right.
Yeah. So they it's all in the background, Steve. So they can all do it. And I know they can in Wisconsin.
Great. Again, stretching the limits of my knowledge.
Now,
Thank you for that
mine too.
clarification.
Your fellow Wisconsinites are here to help you, man.
I appreciate that, John.
No, it's really helpful discussion because these are the things that we can make more clear as we develop documentation for how to do this stuff. So that's perfect. Let's see. I think there was John had noted in the comments that as we look down at step 4, we're going to look at IHE, XPHR, and also International Patient Summary, and that those are different link codes. So we can grab those link codes and make sure that they're accounted for as well. Let's actually look at. Oh, go ahead.
Well, I didn't include the IPS code because, as far as I understood, the U.S. market has not at all picked up the use of IPS. It's more of an international thing. And I think what was mentioned earlier by Matt and by Steve, I think that really is the XPHR used to be known as C32. That's the predecessor to CCDA. So it's possible we look for both XPHR and CCDA, or we do an open one and then filter locally. Either way will work.
Okay, that's where I want to go right now. So you have all three listed. We know that IPS is being worked on as maybe more of a future thing. I want to give everyone a chance to comment on that today. IHE, XPHR, CCDA. So I think we've heard a lot about CCDA, but let's start with IHE, XPHR. That's a mouthful. Let me get that up in my browser here. So scrolling to the top, this is the IHE Patient Care Coordination Technical Framework, Volume 1, Integration Profiles. Within this framework, then we have this one here, which is Exchange of Personal Health Record, or XPHR. And so this describes interactions for exchanging that health record content. Trying to see if there's anything I was going to pick out here. I think it was. Sorry, content modules. Yeah. So, John, you can probably help us out a little bit with this. So if someone is using XPHR, then the content that they're going to get back in response to their request is going to be a CCD. Is that correct?
Well, yeah. In all cases, these are CDA formatted. So if you have a generic CDA processing ability, it won't matter to you if it's XPHR or CCDA. CCDA, like I said, XPHR was picked up by HITSB as C32, which is really what most people called it for the longest time because it was easier to say. That was used as input to the consolidated CDA, the CCDA joint work item between IHE and HL7 that produced the CCDA specifications. So ultimately, they are, to anybody but the most nitpicky, they all look the same. They all have allergies, meds, problems. They're all, laid out rather similar because of the CDA underpinning. And really the question is, if we see no one doing C32s anymore because under the current regulations, they have to do CCDA, then you can simplify your processing abilities. You don't have to support a broader stock. You can focus purely on the consolidated CDA. So that's kind of this market question that you're trying to ask.
Yeah, okay. So the IHE XPHR, you would expect to get CDA in return. And of course, as we know, CDA, there's tons of documents out there that are CDA, whereas some of them could specifically be documents that are within the CCDA spec, but you could get any CDA. Is that on track?
Yeah, I think so. And this gets to something that Matt brought up. If you're looking for broad query, like, gee, I don't know who has last seen this patient because they're unconscious and I don't know where they've been, looking for CDAs is probably your best bet, because you'll be able to process them down to the allergies, meds, and stuff that you care about. If by chance, though, they say, hey, I go to this Texas facility and the only thing they have is a PDF, then you'll want the PDF and you'll have to put that in front of a human to read. So this gets to this freshest. Freshest might be a PDF. You don't know. We all hope CCDA is available, for everybody as the freshest information, but realistically, it might, might not be found anywhere, and you have to ask for a fax. Yes, I said that.
Okay. Let's look at CCDA. So hopefully most of us are familiar with that there's a set of documents that are described in CCDA. Sorry, just blowing up the size of my screen here. So you can expect that if you ask for something in CCDA, it's going to be one of these documents that I've highlighted. So that's nice. And I think we can down the road look into which of these documents would we want to prioritize that would have information that an EMT or paramedic would want. But essentially within those documents, you have all of these sections. Each document contains a different kind of collection of these sections where we start to get some of the stuff that EMTs are going to want, like allergies. So CDA is nice because you've got a fairly constrained set of documents that you need to be able to understand. And then go ahead.
For that LOINC code, then we're looking specifically for the CCD, that third one.
Got it right. Okay. Okay, so then that might be an interesting question to look at here. CCD is clearly relevant to an EMT or paramedic. Are there others from this list that are relevant to them, or not really?
We've seen some of our EMS partners poll, and there's LOINC codes associated with this, discharge summary and progress note specifically. Discharge summary being like past hospital visits for deeper information that I was talking about earlier. Same with progress notes, but more for ambulatory visits.
Okay, so they are potentially getting some relevant info out of those in addition to the CCD.
Right. In addition, I think is the key to John's point earlier. The CCD, if you're going to do nothing else, the CCD is a great way to start filtering and presenting that in an awful way. Yeah.
Yeah, we certainly call for the discharge summary in the broader flow, Josh, when we're looking to do the NEMSIS reporting based on the discharge.
Right. When you want the hospital outcome from the specific hospital that you took the patient to, then you want their discharge summary and you get their diagnoses and things like that.
The discharge summaries, I think, are a little more broad on the format that is universally across the country. I think that's true. Is that?
I think that's true as well. Yes.
because some discharge summaries are truly just going to be PDFs.
Oh,
but some of them will be CCDA discharge summaries. Some of them will be other templates. Again, they're all rather similar if they're CDA, but
yeah. Okay. Thought I had another question, but it slipped me. Yeah, it's gone. Okay, let's look at international patient summary. So international patient summary is the newer thing. As John mentioned, it's getting some uptake internationally. I think still trial use kind of level of maturity. So I wonder if any of you have some insights in terms of where we might see things going here in the US with uptake of the IPS in the future. Okay, so it sounds like we don't know on that. Amit, would you have any insights here about the developments of IPS?
Yeah. Let me know. Can you hear me? It took
Yes.
me a second to switch devices. Yeah, John had mentioned in the US, IPS has had slower uptake with, a lot of the vendors here. However, internationally, there's been, more adoption, implementation, testing. Last European Connectathon, I think there was almost under a dozen vendors that tested IPS. That said, there's common pieces or building blocks that the IPS is built off of that folks can take advantage of. So I think today, if people queried for it, they wouldn't be able to find the document, but it's something in the future that would be easily leveraged based off of any of the CCDA work or other things.
Okay, so something to probably keep on our radar to support in the future. And sounds like it, if you have built support for things like CCDA, then there'd be less of a lift to start
Exactly.
doing
And
IPS.
and especially because IPS is geared for that unplanned health information exchange, there could be other areas where you may be receiving that information from. The other thing in the US too is there's been discussions in terms of for like tribal health or indigenous nations, like adopting IPS as well, since their trading partners may be, Canada, US, Mexico, for example, in the North America.
Hmm.
And then to Matt's question, so he had asked, is there any requirement for IPS? And so I don't think there's a requirement yet. And of course, that's what drives a lot of the adoption today. I mean, once it's a requirement or mandate or penalty, that's when, we see that implementation happening. That said, the other piece is when there's enough of a low hanging fruit, that's also an option for folks. And so internationally, again, like I think it was G7, WHO, the GDHP, Global Digital Health Partnership, they've all endorsed or promoted IPS. So we could predict seeing that, down the line.
Okay, thanks. Okay, I'll pause here. I want to talk about step number 5 next, but before we do, which is picking the freshest or most recent or best medical summary to request and retrieve. Just want to pause on what we've covered so far. I hope that we caught all the comments in the chat, but if there were any that we glossed over too much or missed, then now's your chance. Take yourself off mute and make sure that we cover your comment or any other comments on this overall discussion of these types of documents that we would be looking for. Okay. Let's talk about step number 5. I don't know that we'll need to spend a real long on this, but on a past task force call, I remember that it did come up. It was when we were reviewing the overall sequence diagram for EMS interoperability, and there were some questions or suggestions from people about, well, do we update the diagram to somehow explain what we mean by freshest or best? So that might I just want to see if that's anything that any of you want to discuss a little further. Like, so you put in a query, you get some responses back from that query. Essentially, you get a list of available documents. Now you got to decide which document or multiple documents you're actually going to ask for. And there's some simple stuff, obviously, like the date of an encounter or things like that you might want to pick some more recent things, but maybe there's other considerations too. So anyone with some experience in that area in terms of parsing through that list of documents and figuring out which ones to actually request for your EMT? Maybe let me ask this. If there is a CCD that's available, continuity of care document, is that typically coming from a specific healthcare provider, or is that something that has been compiled by the network, like the HIE, that may have data from multiple sources?
It depends. So it depends on where you're getting it from. If you're getting it from an HIE, yes, it's generally conglomerated from multiple support sources. If you're getting it through a national framework, or you're getting it through like the health exchange, or you're getting it that way, it's generally from one data source, which generally is a hospital's EMR or something like that. But the reason I say that specifically is because you have cases like the University of Pennsylvania, who has a different EMR for their inpatient and outpatient suites. And so you'll need to get 6 summary of care documents from both if you want both. So there's a little nuance there, but at the same time, on national frameworks, you're generally getting it from the source. When you're querying from HIEs, you're generally getting conglomerate documents, but I'll let the HIEs speak for themselves there.
Yeah, any comments from the HIEs on what you do to potentially compile CCDs from multiple sources?
Josh, it's a process on the back end, but there can be 2 types of queries. So it can be stable documents, so provider specific documents, or there can be network wide documents that can be requested. And those network wide documents, depending on the vendor and backend, our current system at Wishin and from Wishin is not by default deduplicated, but the new system we're creating duplicated, and this is specific to us, where we can apply some of the FHIR logic, where you can pick and choose what data elements, pick and choose which sources. But for the provider side, we can also apply filtering so that there's not duplicate data coming in. So if you're an Epic facility that has care everywhere, care quality, you can filter out all Epic. That may be also something, well, it's reasonable to say it's something that can also be applied to EMS vendors if they're getting information through a QHIN or No2 or something, where, hey, if you're already getting this information elsewhere, we can filter that out so you're not having to sift through duplicate documents. So I don't know if that helped or maybe a little more fuzzy, but we can do any pick your flavor on how you want to consume data.
And just to add to that, on the technology perspective, to John's point of having that person in the middle actually focusing the caregiver for what they actually need in the EMS run, there are ways, even if you get duplicate documents, to understand what data elements inside the medications and allergies, for example, are duplicated, so that you don't present a list of essentially duplicate medications and duplicate allergies and other things to a clinician that we can talk to.
Right. Like at the tech level, it's easy enough to see if they're allergic to penicillin in both documents. We only need to show it once. So I guess there's some work. If you're connecting through an HIE, then depending on the HIE's capabilities, you may be able to get a CCD that has already been merged from multiple sources and kind of represents the best known summary of that patient. If you're connecting through a national network, you're probably getting CCDs directly from the various sources, like a hospital they went to, and then you're going to need to do some of that work for your users to deduplicate and show them just the highlights.
Yeah, and that's kind of what's wrapped in the words under number 5, which is pick the freshest or best entry from the available document entry. So you don't just look for the freshest document, but you also have to be looking at the data element level. And yeah, sometimes an allergy has contra indicators in a different document, so it's not easy to necessarily know what the right thing is. But generally, if you've got a use case, you're probably not worried about overly providing detailed information. You're probably more worried about loss of important information. So you kind of will need to be use case algorithmic. But yeah. And yeah, if you're querying across something like the eHealth Exchange, you're going to get, N medical summaries from N different organizations, and they will probably have, lots of repetition in them because they're medical summaries. Whereas, I think there are some of the QHINs that are indicating that they will provide you a summary of all of their participants. And you'll get one. So all of the above is likely to happen, which is why you kind of need an intermediary that's specific to your EMT needs.
Yeah. Okay. I want to ask just a basic question, just to make sure. Are we confident that if we ask for something in CCDA that we're going to get a level 3 CCDA with parsable data, or is that not an assumption we can make?
Repeat the
You
question.
say that.
Yeah.
So go ahead, Matt. If you had some, I would just, if you could repeat that, Josh, so I can.
Yeah. If we ask for a CCDA document, in fact, let's just focus on a continuity of care document in CCDA. Can we be confident that it's going to come back in a level 3 CCDA or level 3 CDA where we know that we have parsable data? Or is it possible we're going to get a level 1, which is just a wrapper with a PDF, or a level 2, which only has sections, is only coded to the section level?
I'll say from the Wishin side, and again, if you've seen one HIE, you've seen one HIE.
Yeah.
I mean, but what we do is only accept V3 in a standard template that can be consumed by a foreign system. So it has to conform to that XML or an XML template that can be ingested. Discrete data.
Okay.
Like Again, stretching, but I think that's where some of the more ambulatory vendors are using C32. I won't name them, but it's very difficult to get them off of that. And the data is not very usable as it comes to sharing it downstream.
Mm-hmm. And Matt, did you have a comment on that, on CCDA levels?
No, nothing additional.
Okay.
Yeah, the only additional thing I'll put out there is if the data supplier is using certified product, then it has to be.
Okay.
So, but to Steve's point, ambulatories are not required to do that yet. So you might get a PDF, or you might just get a level 2.
Okay.
That's what the whole QHIN is trying to drive us towards is perfect, but good enough is sometimes what you'll get.
Yeah.
Yep. And hence the focus on the CCDA and that opportunity to ingest discrete data, since certified health IT is required to be able to export it, at least if they've certified to that functionality or as a complete EHR.
Okay.
Which might be another reason to query only for that link code.
Mm-hmm. Yeah. So if you're getting a CCD in the CCDA format from a hospital, like in that scenario, it's going to be level 3. It's going to be discrete data, right?
Yeah.
Okay.
And I mean, and at this point too, I think it's important to understand things like the information blocking rule and things like that too, and conditions of certification, because if you're using that certified health IT module, you are, required to be able to produce those documents.
Okay. Okay, so back around to fresh as their best entry, it sounds like we would want to prioritize CCDs or even only ask for CCDs, depending. I might kind of write up on the wiki. I think I'll kind of write up a little bit of what we discussed today. That you might just ask for only CCDs, or you might ask for you might leave your ask unconstrained, look through the list of responses, and then try to prioritize anything on that list that's a CCD or something else you may be able to process. And then you go ahead and request that document or maybe a handful of documents that seem to be recent and complete, or well, recent. I guess you can't tell how complete they are till you get the content, but at least recent and relevant. Then get the content back, then parse through, do some deduplication. If you're going through an HIE, then you may have the benefit of that particular HIE having done kind of a pre-consolidation where they can deliver a CCD from the HIE that represents data from multiple sources. So I think that's kind of what it's come to based on my understanding of the discussion. Anything I got wrong there? Okay, great. So then you retrieve the document, and we'll talk in a future call about the actual content in that document and which pieces, which data elements to parse out that the EMT or paramedic needs for their care of the patient. But I think for today, we've at least identified standards and profiles to use, what kind of data and content types we expect. So that's fantastic. Okay. Let's see. So yeah, let me just kind of throw it out there. Did we answer both of today's questions? Anything else that we still need to kind of go back to and work on some more? Okay, great. So after we end today's call, if you could just fill out the quick survey that we have to see how today's call went, and if you got information that was important to you that you needed, that would be great. Lisa, would you be able to put the survey link in the chat for us? There's also the QR code. Wow, you're fast. There's a QR code on the screen here too. It's just a 3-question survey, so it would take like 2 minutes to make sure that we know that we're on track or maybe need to adjust our approach. Okay. So next steps, the survey. When you get off the call today, we're going a little short today, so you got all kinds of time to do the 2-minute survey. The task force email group, if you're not already signed up for it, then get on that. The GitHub repo and wiki. So after last month's call, I updated the wiki page about information that we discussed about how EMS would get outcome data from the hospital. So it was that section that I did. So today, after our call ends, I will update the wiki again based on all the great discussion we had this morning or this afternoon about doing the patient medical history step. The November 9th task force topic, as I mentioned, will be patient identification. So we're going to go back up to the very beginning of the workflow and say, okay, EMS is showing up on the scene. How do we figure out who this patient is enough to be able to start interacting with the network and potentially getting the patient's medical history? What if we still don't know who the patient is and we can't get their medical history, but we get them to the hospital? Can we still make sure that we in the hospital have, exchanged identifiers or whatever, so that later, once the hospital discharges the patient, we can still get their outcomes, even if we didn't know who they were or hadn't really, definitively established their identity at the time we dropped them off at the hospital. So that's going to be the kind of stuff we'll discuss there. And then in December, as I mentioned, no task force call because there will be the ONC annual meeting and the EMS Data Summit on Friday the 15th. I do see we have Eric Cheney with us from the Office of EMS. Eric, anything that you would like to discuss or share with us about the Data Summit?
No, just if you haven't signed up to participate, please do so. Remember, you're not just limited to the section on EMS. The entire Data Summit is probably worth everybody on this call's attention. If you have questions about it, please reach out. Myself or Rachel Abbey will get you the information you need. But thanks for your participation in this group.
Great. Thanks, Eric.
Jonathan, you've got your hand up. Sorry.
Hey, no, just wondering if there's an agenda or an attendee list. Either way would be great to know this meeting.
There's no attendee list yet, and we have a rough agenda, but not one that's ready for prime time yet. We should have that done we're hoping to have it done by the end of this week. So give us till early next week and we should be able to get that out for you. But the times are all set, 12 to 3:30. That's set in stone. And we should more to come on that, Jonathan.
Yeah, Eric, do you envision, and I won't editorialize on this, but do you envision that it will be different from the Nemesis piece that we had where
very much so.
Okay.
Very much so.
Great. Thank you. I thought the one in 2020 was fantastic. Let me just say, I thought that was a phenomenal gathering of people from all over the place. So if it's anything like that, that'd be great.
Perfect. Thanks, John.
Great. Amit has put some additional resources in the chat that you can take a look at, as well as the flyer for the EMS Data Summit. If you go to the Nemesis homepage, there is a blurb in the software vendor news. So you scroll down a little bit and it's on the right. That is a link to an announcement about the EMS Data Summit. Okay, so with that, we are wrapped up for today's call. So again, reminder to just quickly do the survey for today's call so we can know how things went. We will look forward to seeing you all in November and talk about patient identification. Thanks to everyone for all the contribution on today's call. I know it was really helpful for me in particular to better understand that step of the workflow. And so I really appreciate all the contributions today and hope you all have a great rest of the day.